All righty.
Mike, should I get started then or give it a couple?
Yeah, I'll go ahead and get started. So thanks everybody for joining us. Babak will be back online shortly. So this is the larynx cancer version of the virtual tumor board. So thanks everyone for taking the time to attend. Thanks to all the fellows. Any faculty who join, please shoot me I'll be manning the chat box. Shoot me a quick message just to let me know you're here so we can include you in the discussion as well. For those who have comments or questions during the course of the presentations, please enter them in the chat box and then we'll bring them to the discussion as time goes along. So our first presenter is Chase Eaton out of UCSF, who's going to start the discussion tonight. Thank you, Chase.
Yeah.
All right.
Great. Thanks, Mike. Thanks, Mike, for setting this up, and JJ. It's really a cool thing to be doing right now. Yeah, thanks for having me. So let me share my screen here. Let me know how that looks. Are you able to see that?
Not yet, but it looks like it's going. So 1 second. There we go. Yeah.
Yeah, it's up. Perfect. Okay, so I'm going to be talking about salvage laryngectomy, some of the
Chase,
both
you may
ablative
want
and
to
reconstructive considerations and things
Chase,
to think about it.
Chase, can you hear me? You may want to switch it to the whole version,
Yeah.
presenter version. There you go.
Okay.
Like a slideshow or
Play from current. Yeah. Okay. How does that look?
Perfect. There you go.
That looks good.
Okay. Okay. So yes, salvage laryngectomy, a very common procedure for all of us. I find these to be both, enjoyable surgeries, but also challenging. There's a lot of different things to think about. So I'm going to go through an interesting case I had that was also quite challenging. And so looking forward to everyone's opinion on this. So this patient is a 79-year-old man. He's a 60-pack-year smoker. He is a CEO of a shipping company, travels around a lot, big speaker. He went to an outside ENT in mid-2017 for voice changes and was diagnosed with verrucous hyperplasia. And for this, underwent multiple KT ablations, endoscopic resections. They never found any cancer in this specimen. Unfortunately, after all this lesion or lesions continued to grow, then presented back with airway obstruction and a fixed cord. And finally, on that endoscopic resection, they found verrucous carcinoma. So that prompted a further workup. And just briefly to go through this verrucous carcinoma, it's a fairly uncommon diagnosis. We see it most often in the oral cavity, but it can be seen in the larynx as well. You may know that this is considered low grade. It's a well-differentiated squame. It's often described as kind of warty, just like these pictures are shown here. Locally aggressive, fortunately very low metastatic potential. This is clinically indistinguishable from verrucous hyperplasia, which is often about from a leukoplakic lesion. The key thing here is the biopsy. So if you were to just do a punch biopsy of one of these lesions, you may miss the fact that it's invasive. So it's really important to do a deep incisional biopsy. And I've read that really this transition from hyperplasia to carcinoma is pretty consistent. So some people suggest that whenever you get this diagnosis of verrucous hyperplasia, you just treat it as a cancer and remove it. And for that reason, really is a surgical disease. So here's the scans that the outside ENT obtained. Sorry, I can't go through them, but a couple still shots on the left here. Lower down, this is at the level of the cricoid, and you can see that there's some sort of process, mass of the right glottis invading the cricoid cartilage, and then up a little more superiorly, you can see fullness in the right cord area where we had the fixed cord, questionable invasion of that thyroid cartilage. He is older, so this could just be some kind of changes in the cartilage. But just to go through the laryngeal squame staging from the 8th edition, we can see here that he's, for sure, it does appear that there's some cartilage invasion, which would probably make him a T4 by most of our staging. Fortunately, the outside ENT staged him as a clinical T3. They talked about his treatment options. Patient elected for radiation only, given the fact that he uses his voice a lot for his job. So he completed this outside in 2018. Was treated to the larynx only, not to the neck, at least according to the notes that we received. About 3 months after this, he came to UCSF with airway compromise, was brought in. In scope, he was found to have a fixed corpses and found squam on my pathology. You got this repeat CT scan. So you can see quite a difference from his pre-treatment scan. Clearly, this is a T4 tumor invading cartilage. There appears to be some evidence of chondrodendrosis here as well. And you can see really no discernible airway, so significantly worse. And I think everyone would be comfortable saying that the next step for this gentleman is salvage TL.
This was 4 months?
Yeah.
After radiation? How long?
3 months after radiation.
Wow, 3 months after radiation. So sorry, I my computer crashed for a second. So obviously a very unfortunate case. Mark, what would you say? Mike, can you hear me?
You're muted, Mike.
He's muted.
Yeah, sorry about that. Airway-wise, they're getting into trouble, but are not an extremist yet. Is that correct?
No, he came to the UCS ED in extremis, so he had to be taken pretty emergently for an awake trach.
Yeah. Yeah, and so I think there's a big learning point on that. You know, these patients, especially a 79-year-old who had looks like some big osteophytes, I'm sure his neck is creaned forward a little bit. One, this isn't a trivial procedure just to get the airway established. And two, you want to err on the side of, so it's always tough. You don't want to cut in a tumor if you don't have to, but you would want to do a high tracheostomy here to make sure that when you go back for your planned laryngectomy, you have enough end of a trachea to actually bring it out to the cervical skin without needing to do a manubrial resection and a mediastinal stoma. The concern here is, obviously in the acute phase, you want to stabilize the airway and then get a tissue diagnosis and then repeat staging to make sure that you had a good assessment of not just the local regional disease, but to make sure it hasn't progressed distantly. Now, as you mentioned, these epicyclic seems to be one that may have a more poorly differentiated component outside of just the papillary. So just making sure you're not missing anything.
Yeah. So this is the biggest problem we have. Give me 1 second.
And while you're pulling up your computer, one other thought on this. So if the person were not an airway extremis, you can consider, if you feel like a lot of this haziness outside of the larynx, this extralaryngeal soft tissue is tumor, you can sometimes just do a needle biopsy of that to avoid the need to do a tracheostomy, because that by definition just makes it a bit messier operation if you've had a previous trach and you're worried about putting them to sleep to do a biopsy. So you could just do a, fine needle aspiration to achieve a tissue diagnosis of recurrence, and then, consider, avoiding the trach. But in this one, it sounded like he needed it just to stabilize the air.
Yeah. So, this is a case that you see all the time, and unfortunately, we keep seeing it, that the first diagnosis is not correct, and that's the price the patient pays. First of all, T3, strictly speaking, that would be advanced stage thyroid cancer, and I'm not sure if, to begin with, single modality treatment is adequate. And as you can see, that once you don't have the right treatment, the patient, this is 4 months, is basically, this is persistent disease. And now you have as you said, you have an airway emergency, you have compromised field, you have radiated field, and it's really bad. All right, Chase, Go ahead, tell us what happened. I see Dr. Shah is trying to join. Dr. Shah, would you like to make a comment if your audio is working? Okay, go ahead, Chase.
Okay, yeah. So to continue here, we obviously staged him now at a T4A after treatment. Again, got him set up for a salvage TL. So here's some of the challenges we face with salvage TLs. Sometimes we think it's the patient's last resort at cure. We often, as in this case, don't really understand or know the treatment specifics prior to them showing up. Lots of scar tissue fibrosis. These patients have a really hard time healing. So we got to do everything we can to make sure they're optimized prior to surgery. So here's just one of my first things to possibly open up to the group. Whether everyone performs elective, this patient's N0, whether patients perform elective neck dissections in a salvage TL setting, and in what scenario.
Oh, that's a great question. Let's open it up for discussion. So start that. Jeff, what would you do?
I think this is a really interesting question because I sort of debate it every time I do a total laryngectomy. In general, I favor a bilateral elective neck dissection for any circumstance where I'm doing a salvage laryngectomy. I really just don't want to be caught in a circumstance where I've successfully salvaged a patient locally, and then you only to find that they met out in the neck because you didn't do the neck dissection, like 6 months later, because then you probably have lost a patient. And so I feel like it's really important to consider that as if you're going to do one operation and this is your patient's last chance for cure, to do a total laryngectomy and bilateral neck dissection. Now, that being said, I think there are specific circumstances where you can make a consideration for only doing the highest risk neck. For example, most glottic cancers tend not to metastasize to the neck. So if you get a recurrence in the glottis and it's a low volume recurrence, you're still doing a TL, you could probably make an argument to not dissect the neck if your PET scan is negative and your CAT scan is negative. In my practice, I've only done, I think, maybe 1 or 2 patients where I elected not to do one of the necks. I always did at least one neck dissection, but not to do the bilateral. Mm-hmm. And I haven't regretted that decision yet. But there is some single institutional data that looks at incidental pathology positive nodes in the elective bilateral neck dissection and salvage laryngectomy. And I think the number, if I have it right, is either about 10%. It's not high when they're radiologically negative, but it's high enough where, like, if you're trying to get everybody to be a win, that one outlier can be a huge problem. So in general, I favor bilateral neck dissection in the salvage setting when you're doing a total laryngectomy.
Right, Mike?
Yeah, I do as well. I agree. There's a little bit of data to say if you were N0 before and N0 after treatment, you could avoid it. My standard practice typically has been to address it, but I think it is an important thing to consider because it's not trivial. You're setting that patient up to the risk of carotid exposure more readily. And so we're in all these patients weighing the pluses and minuses, and some of it depends on, for example, like if you're doing a functional laryngectomy, obviously not for cancer, you wouldn't do neck dissections, which I think nobody here would argue to do them in that setting. But it seems like a minor point, but it's actually a pretty significant one because patients with poor tissue quality are going to heal poorly, and you'd hate to have them cancer-free and then ultimately have an issue with a carotid exposure or rupture. So I do for the vast majority of patients, even when they are N0, but again, I think it's more of a convention, and I'm not overly comfortable with the data we have on the N0, N0 and avoiding it.
I think Don is on the line. Don, Dr. Weed, are you on? Would you like to make a comment regarding elective neck dissection in advanced larynx without any evidence of nodal disease?
Sure. I think you have to, each of those needs to be individualized. I mean, if it's a chemoradiation failure, N0, bilateral necks that's pretty significant morbidity. Even if you don't end up with carotid exposure, your lymphedema consequences are potentially quite significant. Now, again, if their neck preoperatively is soft and supple, they're probably not going to have such a bad outcome. But narrow field radiation, probably wouldn't have nodal disease that's N0. But I think you just have to look at them individually.
Yeah.
And I think our institution is one of the institutions with low percentage of positive disease in the N0 neck and salvage laryngectomy specifically. But then I would also say that in these patients, we have a low threshold for putting vascularized tissue for recon.
Oh yeah, 100%.
And if you're going to do that, you're going to dissect at least that neck for sure.
Yeah. Okay. So that's so as you can see, this is a much more complex topic, as we all think. We all start, when we come out of fellowship, we just like bilateral neck everybody. But it's absolutely true, as Jeff and Mike and Don all mentioned. It's not without its morbidity, but at the same time, it's a very delicate decision, and it's a very difficult decision that you really don't know. And I can see that Chase already put up the data. Go ahead, Chase. Just explain the data.
Yeah, Jeff, I don't know if this is the paper you were mentioning, but this is the largest group of patients I could find looking at this question out of Michigan, and they found an occult nodal met rate of 17% in their clinical N0X. And this is kind of what I follow for my practice. I'll do a unilateral neck dissection only if it's a very lateralized tumor. If it's crossing midline, I'll do bilateral, and if it's supraglottic, I'll do bilateral as well. But what I often think about is the risk of hypoparathyroidism with the bilateral dissections. So if I could avoid it, I do my best to.
Yeah.
And there's also been some very small studies looking at patients who are clinically N positive prior to radiation, but clinically N0 at the time of salvage, and those numbers seem to be about the same, right around 20%.
Yeah, I think so. For chemo-radiated patient that previously didn't have any nodal disease, especially nowadays with good PET CTs, and afterward they still don't have, and it's only local failure, you could argue that should we do bilateral or not? I don't think we know the answer yet. I don't think anybody would harm anybody, would criticize somebody heavily for doing it. But at the same time, as Don eloquently said, and Jeff, it's not without this complication. And personally, every time I have done after a chemo RT, not RT alone, chemo RT, without any evidence of prior disease, it's always been negative, and we still do them. But through the years, my field is becoming shorter and smaller and smaller. It's just like low level 2, low level 3, 4. But maybe I'm wrong. I don't know. But the point for everybody on the call is just, it's a delicate decision. It always pays, as Don said, examine the patient, examine the neck, look at the imaging very carefully. Look at the original PET scan before treatment if you can get it. Those are all very helpful. And a lot of times you might see nodes that the radiologists have missed it, and that might make the difference. All right, go ahead, Chase. We're gonna finish too.
I could interrupt for a second. I'm curious from my colleagues, how many of you do a level 6 central compartment dissection with your laryngectomy, either ipsilateral or bilateral at the time of surgery? Are there circumstances that you consider doing a central compartment dissection depending on the tumor location?
I do for subglottic extension and for significant hypopharyngeal extension, but for supraglottic and glottic, I don't always.
Mm-hmm.
I would agree with that.
Yeah, same here. I don't do a thorough level 6 that you would do for like medullary. On the side of the tumor, I usually just cut the thyroid and keep the thyroid with the specimen, and just all the nodes that come with the thyroid goes with it. And the contralateral side, and nowadays with the harmonic is easy. I just cut the isthmus, and I push the entire thyroid away from the larynx, and that keeps my parathyroid and everything out of the way. And I don't necessarily chase those nodes.
Good. So that kind of covers this next thing. We could breeze by this, but lobectomy versus total thyroid. I think it's important to know that after radiation, hypothyroidism normally peaks at about a year. So even though this patient was 3 months status post-radiation, they weren't on Synthroid at this point, but the chances are they were going to need it at some point. And then even patients who weren't hypothyroid going into their salvage TL, most of them end up being hypothyroid after a salvage TL. So
absolutely.
This is despite thyroid low and neck dissection. So just something to be aware of. We should always be checking TSH in these patients.
100%. Actually, I start everybody after laryngectomy on a low dose thyroid replacement, regardless if they have been on thyroid. You can do 50, 75, 100, just doesn't need to be. But I learned my lesson. But absolutely, as you said, a lot of these, even when before the operation, they are not hypothyroid. After your operation, they're definitely hypothyroid.
Yeah. Okay, so this patient underwent a salvage TL. We did a unilateral neck dissection on them. And then the next part is the reconstruction. And we all know the goals of reconstruction for our TL patients. Options available: primary closure, regional flap, free flap. So definitely interested in hear how everyone would manage this.
So I see Arno finally finished the mega flap and joining us. So perfect timing. Arno, what's your choice for reconstruction after salvage laryngectomy?
So the mega flap is ongoing, but wish I could say it was done. My choice is generally ALT is my most common choice, just because it gives me vascularized muscle, which I think helps with wound healing. It gives me tissue to augment the pharynx. It kind of, I think the versatility of the ALT is unmatched really when it comes to most laryngectomy defects. That said, depends on the patient. I've also sometimes done pec muscle only or forearm or other things, but ALT tends to be my go-to.
Yeah, same here. I love ALT, and you can raise it at the same time as doing the other thing. And just as you said, unlimited tissue, really minimal donor side morbidity. You can shape it the way. And actually, the one thing I would say, after you put an ALT, it's a little bit thicker than radial forearm. Their neck contour looks so much better. It doesn't have that kind of empty looking neck, which, not for nothing, but yeah. What about others? Don, what's the choice in Miami?
You have to ask a lot of people that, but my choice generally, I actually love the forearm for that, even though I like the ALT and pec flap. You can't argue with a pec flap and a vessel depleted, terrible looking neck for a TL specifically.
Mike?
I agree with all that's been said. I kind of follow Arno's algorithm there. I do, in the Hoosier state, we have a lot of adipose tissue. So if they have enough mucosa of the pharynx to close, I do the muscle only pig in a blanket technique. So just overlay with muscle and obliterate the dead space, and it tends to work very well. And I think they tolerate it well also.
Yeah, I have to say the same thing that, so I see, Chase, that you put a T-shaped closure. We were Memorial folks, we would never, ever do that. Like, never do the T because it always leaks. But, I mean, there is a place for it. Same as Mike was said, a lot of time when I don't have a mucosal defect, I do a primary closure and then put a muscle outlay, just a pectoral muscle only. And that works very well, especially when you're at VA and they have no leg, or the leg is terrible. It works. I see Dr. McCammon. Susan, what do you guys do in Alabama for reconstruction of the laryngectomy defects after salvage?
Almost always we'll use a radial forearm flap. Sometimes we've on occasion used an ALT, and then if the neck is just a train wreck, we'll use a pec flap. Yeah. Often we'll do muscle only. And then one thing we've started doing is we've been dividing the sternal head of the SCM to make the stoma flatter. And we've started tacking that down to the prevertebral fascia over to cover up the vessels, especially
the carotid,
to protect the carotid. We had an interesting case a couple of weeks ago where we did that on one side. We actually did a patch radial forearm for the pharyngostomy closure, and because of where the pedicle lay, we were not able to bring the SCM over and tack it down over the vessels, great vessels in that side of the neck. And we got a leak, unfortunately, and things broke down, and the side with the SCM tacked down stayed intact much better than the other side, which really became a big florid mess. So I've started doing that, and I've been really happy with it.
Sure. All right. So as you can see, there are options. Go ahead, Chase.
Yeah. So I sent this paper out to JJ to send out. This is a paper from a couple of years back, a fairly large multi-institutional study looking at pharyngeal closure techniques and salvage TL. And I believe there's a new one in the works right now, but it's not out yet. So I think there's some salient points to take from this. They compared primary closure alone to PEC and free flap. And I think we all know that primary closure alone is just not sufficient. You need some sort of vascularized tissue in there to help close it off. So we'll know about the PEC major flap. It's a great flap. Muscle or skin can be used. Jonas Johnson looked at the PEC myocutaneous flap, and they noted a really high complication rate, almost 50%, high fistula rate of 29%. So what they concluded was that if you're in a position where you can't do primary closure in an onlay muscle, you need some sort of skin. We shouldn't be using a PEC, but we should be thinking about the free flap. So free flaps, really any situation where you can't close primarily. So the number is about 1.5 centimeters of posterior pharyngeal wall. We should be thinking of a free flap. If you compare the free flap versus the onlay PEC flap, when you can close primarily, this paper showed that leak rates were improved compared to primary closure. There was really no difference between onlay PEC and free flap. But what I thought was interesting was that when a fistula develops, the length of time that fistula lasted was smaller with the free flap as compared to the onlay PEC. So really, Babak, as you said, it really, and as everyone said, it really comes down to morbidity. And I just think the morbidity of an ALT or forearm is much less than that of a PEC. So I often go for the ALT first, forearm second, PEC after that, but use the PEC often for more disaster scenarios.
And I would reiterate what.
So I was just going to quickly just show some.
Go ahead.
Oh, go ahead.
Yeah, what Don said, don't underestimate the morbidity of a neck dissection and a PEC flap on that shoulder. So that's one of the reasons that we kind of like the ALT or radial forearm, because the PEC, first of all, is a good salvage option, God forbid something goes wrong. And also, really, if the patient is good functional status, it's better to try to maintain the movement function of the shoulders. All right. ALT, okay. Chase, you're done?
Yeah. Yeah.
Hello?
Yeah. I was just going to quickly show some pictures of the ALT inset. I think what's good about the ALT inset, I'm sorry, could you hear me now?
Yes.
Yeah, I think what's great about the ALT is you could use the extra skin to use off excess tissue that's resected on the neck. So I think that's a really a big benefit of the ALT. And just to close out this case, the big issue here was that this tumor invaded the subglottis, and we had to resect about 4 rings, pull that trachea up. We used an ALT, and unfortunately on post-op day 10, he had complete dehiscence of the tracheal, complete tracheal dehiscence from the skin and from the flap. So this significantly delayed his healing afterward. We don't have to get into this too much just for time reasons, but I think this was a big part of his issues post-operatively. We thought he could get more radiation, but given the fact that he wasn't healing, this was delayed, and when he found to have a recurrence right at the site of a positive margin at the posterior tracheal ring. So it's something I struggled with, and I wondered if I should have gone back earlier than I did to use some sort of local flap to close things off.
Sure. The great point, as in the interest of time, I'm just going to finish so Jeff can start, but you're absolutely right. The one thing I would tell for the audience is, remember, a surgical complication is actually an oncologic complication. We do know that surgical complication can have a negative impact on survival. And as Chase said, it's very difficult. And sometimes, really there's no good answer for it, but it does affect it. And you're absolutely right. These are tough cases, and these things happen. And I definitely don't have the right answer for it. All right, Jeff, let's start.
There, I'm unmuted now, right? You guys can all hear me now?
Yes. Yeah.
Okay, so I have two cases to present. They're a little bit of archetypal cases, meaning that they're sort of there for purely for discussion. One of them is we'll start with an early laryngeal case followed by an advanced laryngeal case. For our trainees on the call, one of the ways I structured this was to sort of try to appreciate that the nuances of these patients and how they present and looking at it, looking at the cancer, looking at the patient factors, can help significantly change how we think about our plan recommendations. So first I want to present an early larynx cancer case, and actually has two codas, meaning that we'll do a discussion and then I'm going to change the case slightly and ask what the team thinks. So this is a 6-year-old man who presents with hoarseness for the last 6 months that have been progressive. He has no problems eating, drinking, or swallowing with no weight changes. He was seen by an outside ENT who did a CAT scan and biopsy of the larynx, which showed squamous cell carcinoma. He's a significant pack year smoker with 50 pack years. He's also a daily drinker with 2 to 3 beers in the evenings. And social history, he works as a truck driver and is a sole breadwinner for his family. So your clinical examination is benign with no evidence of any lymphadenopathy. He's certainly hoarse, but has no evidence of stridor or shortness of breath and is very comfortable. So you do an office endoscopy is performed. So here's his office endoscopy. This is him both with inspiration and expiration, and essentially you can see he has a left true vocal cord lesion. I'll come back to this photo so people to sort of stare at it and make some comments. But he's got good, or I should say excellent bilateral vocal cord movement. The cancer, the tumor, cancer seems confined to the left true vocal cord only, and he stages a T1A N0 left glottic cancer. And so for
Jeff, is that Reinke's edema on the other side?
Yeah, that's just Reinke's edema. For discussion purposes, you can see my mouse. This whole stuff is just Reinke's edema. The cancer is essentially here on the left true vocal cord. So wanted to talk about first some options for management, what the team would usually do, some considerations within that surgical space and other options, and then considerations for choices. So
all good. Let's see.
Who wants to start up?
From East Coast or West Coast? I guess we have a presentation from California. It's pretty heavy today. So let's see, Chase or Arno, what do you guys want to do?
Yeah, so he'd do great with radiation. The problem is that might be tough for him and his family being a truck driver. So, in terms of oncologic outcomes, I think he would do really well with that. With surgery, it's kind of potentially a one and done. We'll have some voice issues after. So I think he certainly is an option.
Okay.
Just go through both of those.
Cut or buzz? What do you do?
What was that?
Yeah, I said cut or buzz? Radiation, zap him or cut him? Is it radiation or surgery? What's your choice?
I would recommend radiation.
Okay. Arno?
Certainly I'd want him to meet with the radiation oncologist. I'd want to get a sense of this thing of how mobile it is over the vocal cord ligament. I mean, it looks pretty exophytic to me, so I'd probably want to take him for a DL and just get a sense of what this thing, what the deep extension of this thing is. It seems like it's something that would be amenable to a transoral laser resection with reasonable function and afterwards if you're able to preserve the vocal cord ligament. So I would certainly present him with both options and get a sense of what he prefers.
What's your choice?
If it was me?
Yeah. Well, if you're the physician, you're the decider.
Yeah. Hey, doc, I'll do whatever you tell me, doc. Tell me what to do. You know those guys.
I think if I sense that this thing was sliding a bit over on the vocal cord, I think I might excise it.
Okay.
So Arno,
Susan?
Hold on. Arno, can you just elaborate just a small bit, meaning that do you take the patient to the operating room saying you might excise it and you'll make the call intraoperatively so he has, he doesn't know what he's going to get when he wakes up? And then number two, could you just elaborate how you determine its depth of invasion to the lamina propria intraoperatively there? I know there's some tricks, if you could just expand on that a little bit.
So I think whether or not I excise it at the time of the surgery would just depend on my discussion with the patient. I mean, if he was favoring a surgical approach, certainly I would be prepared to excise it at the time of the operation. If I felt it was amenable. I don't really have any tricks other than I would just grab it probably with a cup forceps and just kind of and just get a sense of is it sliding over the lamina propria or not.
Do you do CO2 or KTP?
I would do CO2. Generally, I do the micro manipulator on a microscope.
There's also an old Zytel's technique that to inject the cord, even with saline, but you probably do it, 1% light with epi, and look to see if the lesion lifts off the cord to get a sense of its depth, which is another trick some people use to evaluate its depth. So just want to point that out.
I'm not 100% sure if that's approved for cancer, but yeah, I've seen that technique. So I think that's more like a CIS and others. But yeah. All right, let's ask others. Susan and Mike, who would like to go next?
Susan, you go ahead.
You're mute.
Sorry, I would definitely want to go for a DL, and I'd like to see the anterior commissure a little bit better, and I'd also like to see the subglottis a little bit better. If what we see is really what is there, then I think a CO2 laser excision would be reasonable. I mean, I think I would want to talk to this guy. I know he's a truck driver, and so we think of the inconvenience of a 6-week radiation course as being paramount, but they also often are very high voice users if they use their radios a lot, or if they're in guide trucks, that kind of thing. So
okay,
I'd want to get a better sense of that. Also, I mean, you could cure this with radiation too.
Mike?
Yeah, just quickly, I'd most likely take it out unless there was something that extended beyond what we see here. I would certainly offer a visit with radiation oncology, and I think having that visit before any trip to the OR makes sense, just so they don't get a biased opinion, but I would strongly consider surgery.
And then Don and then Babak, what would you do?
I would.
So,
go ahead, Babak.
I would definitely consider this, as you said. I would definitely. This seems to me like a favorable lesion for laser, so I would definitely consider it. It's as Susan said, even a truck driver, they need their voice. So my big indication is if it's really big, subglottic, very deep, that I need to do type 4, or it goes to the anterior commissure. If none of those, I think this is a perfect candidate for laser.
Don?
So the way I would manage this, he needs an endoscopy. It looks like this is a bigger lesion than I would excise, and that he would do better with radiation. However, the way I would do it is make a incision with a sickle knife, far lateral on the superior aspect of the cord. And if that mucosal surface elevates with a flap elevator, then I would remove it for biopsy, because that's not going to have a major impact on voice if the patient's willing to have some impact on voice and potentially have an excision. If I thought I needed the laser to do a cordectomy, essentially, then I would recommend radiation.
Okay. Is there anybody here who would consider a KTP laser ablation of this lesion? I just want to know if anybody would say yes to that. So it's interesting. I think among laryngologists, they're on the edge of that curve. There's some individuals, again, from Zytel's that have demonstrated very specifically in select patients KTP laser ablation for certain very early T1 stage larynx cancers. I just want to bring it up because every single head and neck surgeon I've ever talked to says that's like a hard pass, pretty much. So I just want to bring that up. So this individual, I don't actually remember what they went on to get in terms of treatment. I think it was actually surgery. So this is a T1A left glottic cancer. Now we've talked about the anatomical. We talked about some social considerations. Obviously, if you can't get there with a DL, you wouldn't do it. And I'll hold on to voice outcomes for discussion in a second. Same exact case now. Now this patient has a slightly different presentation on your examination. I'm sorry, the presentation is the same, the examination is different. He has a supraglottic lesion. You can see here on the left, just above in the supraglottic region, there's a exophytic mass on the left false focal cord. I have some images shortly. The preepiglottic space is clear, and it's sort of like a pedunculated supraglottic lesion. This is what the lesion looks like. It's a T2N0 supraglottic larynx that is sitting just at the base of the infrahyoid epiglottis and extending onto the false vocal cord that you can see on the left side. For purposes of discussion, we'll say that the true vocal cords are completely clear. If you kind of lift up a little bit, we'll say the anterior commissure is clear. So this is a T2N0 supraglottic larynx, and I'm interested in what the team would do now for this patient.
Did you send for HPV?
No, but we can send for, we'll see it's HPV negative for now. This is a classic smoking-related larynx cancer.
Jeff, quick question before it came up right at the tail end of the other.
Oh, sorry. Yes.
The last one, and I didn't want to interrupt you. The question came from the audience about use of narrowband imaging to, on that one, assess the contralateral corridor just in general. Do you use it in your practice?
I think that depends on availability. We have it. I haven't used it much. There's been a couple papers I've seen that have talked about its benefit in looking at the telangiectasia patterns to be able to judge sort of deeper extent of the tumor that can be visible with the eye. In my mind, that's still a technology that's still being evaluated for its use. I think, you know, an expertise with good, say, a chip-tip scope compared to actually applying narrowband imaging, I'm not sure how much of a significant difference there is. And I'm not trying to downplay it. I'm just trying to say I don't know what the benefit is. But I think for those who are trying to make a decision about a potential like submucosal extension, I think the NBI might be very helpful. But I don't have any. There's been a couple papers I've seen, but it's not really like a slam dunk. I don't know if anybody has any comments.
That's more than laryngology.
Blue-green wavelength, you know, basically captures those wavelengths of light that accentuates vascularity, and so it's been shown for that. It's been shown to have some application in screening for kind of precancerous lesions as well, but I don't regularly use it in my practice. It was brought up. So
yeah, that's a good point. I think something that maybe in the next generation of head and neck cancer surgeons should consider. Okay.
So for this now, same exact patient, but now it's really a T2 enzo supraglottic. I'll start with, we'll go East Coast now. Don, where would you start for this patient? What would your recommendation be? If you have any questions, I can fill you in.
So he's had PET scan. That's how your N0 is, or just CT?
We'll say CT and PET are negative. No evidence of regional disease. Just only the lesion at the local site.
I mean, I think he has two good options. He could have an endoscopic, in my hand, CO2 laser resection with bilateral necks. You I guess, could observe the neck, but I wouldn't for supraglottic, and potentially avoid radiation. If you think he's going to need radiation for sure after your endoscopic resection, it's probably better off having radiation as primary treatment.
Okay. Susan?
I think that I would agree. I think that I would probably treat the primary and the next with radiation.
Oh, so you go straight to radiation, not an endoscopic resection. Okay. Babak?
I have tried to take a few of these out, and I have seen Petra Ambrose does it. She does it much better than I do. These are not easy. I tell you that. You might think that, oh, it's supraglottic, you have more room, but this needs experience. And as Don and Susan said, definitely you need to think about the neck. I have gone away in my first few years. I used to be a little bit more gung-ho. This is also, the margins are not very clear here. So I think this is a tricky lesion. It's definitely doable, but I think at the end of it, I'm still going to be unhappy. So I would definitely send it for HPV. And if it's HPV positive especially, I would 100% send for radiation. But I have to talk to my radiation oncologist to make sure that they at least cover the ipsilateral neck. This is not a case for narrowband. And that's very important, because some of the, if you have someone who is not doing head and neck day in, day out, they might consider, oh, this is small T1, we just do narrow field, and that's going to be a mistake in this case.
Mike?
Yeah, I mean, I would be a little leery of the anterior commissure, even though it's not involved, just to get a margin there. And it's just you took some great pictures, but at least in my hands, the exposure there is a real challenge. And so I would worry about my ability to clear that margin without getting into and disrupting the kind of attachment, ligamentous attachment there. But so probably we'll steer towards external beam radiation.
Okay. Arnold and then Chase?
I would echo everybody else's comments. For me, the T2 supraglottic that I try with the laser is the one that's sitting up high, kind of near the tip of the epiglottis, and then I could just, lop off the end of the epiglottis. This is really tough. This is right up on the anterior commissure. You're going to have millimeter or less margins onto Burroughs ligament. This is also one that easily turns into a T4 quickly, where the cancer kind of tunnels along the Burroughs ligament into the cartilage. So I would be reluctant to do this with surgery and would do a first try with radiation and save surgery for salvage.
And Chase?
Yeah, I agree. It's a lot of surgery to put the patient through, and then likely in the end not feel comfortable that you got around this lesion. So I think radiation.
So for the group, if you elected for surgery, is CO2 laser preferred? Would anybody use the robot? Assuming access is not the issue, like you can get down there.
No.
Not really. Okay, so CO2 laser would be the preferred strategy for a surgical approach.
Would anybody consider supracricoid for this?
You know, I was thinking supracricoid. I don't know. I was thinking about supraglottic, but it's a little bit too close to the. And I have done supraglottic, and it's a beautiful operation, but it's a little bit too low for supraglottic. Supracricoid.
I don't know. I think this is a classic supraglottic case. It's not an easy one, but a supracricoid, you're going to take a lot. I mean, you definitely get wider around it, but you'd take a lot that you don't really need to.
Yeah,
I think the biggest issue. I think the biggest issue with the supraglottic is what was mentioned. If you end up doing it and you don't do a lot of these endoscopically, and then you're uncomfortable with your margin, and then you send them to radiation, they should have just had radiation to begin with. So I would not take this patient for supraglottic laryngectomy without doing an endoscopy first, waking him up, and then telling him what I thought I could do.
Yeah.
And if you do surgery, would everyone do a bilateral neck dissection? Would anybody do a unilateral neck dissection?
Not for supraglottic.
Okay.
Not for this supraglottic that's midline.
And do you guys do it at the time of your CO2 laser resection, or do you stage the neck dissection at a later date?
I would do it at the same time, but
I think the only exception I make is if I do this, and I'm at the end of it, I'm kind of like, what are the margins? I wait for the margins and I see how it is and how it looks. And if it's still not very good and it's deep and it's like tumor everywhere, I would just stop and I wouldn't do a neck dissection, just send them to radiation. Okay. At that point, I've only done basically a gigantic biopsy and it should be okay.
Okay.
But if everything's okay and they have a very good chance of not needing radiation, then I would do. But if I'm doing this and it comes out beautifully and everything's fine, you can do the same time.
Okay. Any other comments on this case specifically? I think this patient ended up going for radiation, but any other comments on this case?
So a couple of points. I think that a few years ago, it came out, there was a paper in ASCO that showed 30% of hypopharynx are HPV positive. And actually that HPV positive does make a difference in the outcome. We looked at supraglottic larynx and that's a little bit lower, it's about 25%, but you do see this that are HPV positive. So I would encourage everybody, all the audience, that think about it, especially for supraglottic hypopharynx, and we just published in Cancer that actually sinonasal tumors up to 25% are HPV positive, and those patients do better. And nowadays with the HPV, we know that the outcome of RT or chemo RT is fantastic, really. So that's one option for these folks. And if they are truly HPV negative, then surgery becomes much more attractive.
Okay, thanks. Just two more codas. What about this T1 glottic cancer with definite anterior commissure involvement? Is there anybody here who would not perform radiation?
That's a nasty looking tumor. That is not, are you sure this is T1? This might be actually in the paraglottic space.
Let's just say that, for argument discussion, excellent movement of the vocal cord. It just goes all the way up to the anterior commissure and it looks ugly, but it's very exophytic. Not a surgical.
I don't know. This doesn't look like a very exophytic. I am a little bit worried. This is kind of a meaty tumor. This is a big tumor.
Yeah.
Your CT scan is completely fine.
So I agree that when you have this kind of anterior commissure involvement, you want to favor radiation, just because clearing that margin surgically with the laser is just very difficult.
Well, I make sure that he doesn't need a chemo RT. I make sure that this is not a T3.
Yeah, the imaging here is very important. I was going with the full glottic movement, just bulky. And then what about this case at the bottom? This is like I think some people's dream case. This is a marble-sized tumor hanging off the left RA epiglottic fold, no piriform sinus involvement, very little endolaryngeal involvement. Now, what would you guys do? Surgery? Don't all speak at once.
I think I would consider surgery for this. This is actually not a bad case for robot either, or laser
Okay.
or robot.
Yeah.
Again, for these cases, I would do send for HPV, but the question is, would you do in the neck?
Yeah, I did. I'm still a little bit of a purist. I still have done the bilateral necks. It's amazing. There's a lot of data out there, but for some reason, lateralized tumors of the supraglottis, whether or not we can do a single versus bilateral neck dissection, some of that data seems to be very lacking, and I wish I had more to go with it. I mean, we know that about 20 to 30% of T1 supraglottic cancers will result in an occult metastasis, kind of like oral cavity. So it's important to do the neck dissections, but whether or not you can get away with a lateralized neck for supraglottic versus a bilateral neck, knowing it's lymphatic drainage, I think is still a tough call.
I might consider unit. I'm just curious to see others, Susan, Don, others. Would you guys consider number one surgery and just unilateral? Because very lateral. This is right above the retinal.
So this is another one you have to understand what patient you're dealing with. This is somebody that you're going to see every 2 months in the office, and it's going to be reliable, and
Yes.
you get probably more imaging of the neck than you would otherwise. A unilateral neck is a reasonable thing to talk about.
Okay.
Yeah,
I'm going to move on to our next case. Thank you for the comments, guys. Just sort of summing up. Surgery versus radiation, definitely considered for oral cavity, or early laryngeal cancer. There are multiple considerations you should think about, most of which we touched on. Some additional ones, you want to think about their pulmonary tolerance. These patients are smokers. The voice outcome, I think the data shows that it's somewhat equivocal, although slightly favoring radiation, but we keep in mind that it's a very selected group who undergo surgery for a glottic cancer. The tumor accessibility and whether you can get there is a huge deal. Duration of episode of care relative to their social considerations, like a truck driver who has to work all the time, it's hard for them to come every day for radiation. That's been brought up. You do want to think about the advantage of a second primary in these smokers, that if there's a 20-30% of a second primary in their lifetime, that a surgical option allows you to address a second primary more readily, whereas if you give radiation for like a T1A and then they develop a supraglottic tumor or oropharyngeal tumor, you might be stuck with a surgical option only, which might be less than ideal. And just remember that for supraglottic tumors, lymph node management is very important. Okay, so our last case for easy discussion, like always, is an advanced larynx cancer case, a discussion of treatment equipoise. So 55-year-old female, similar to previous case, with 6 months of progressive hoarseness dysphagia, and this patient has had a 30-pound weight loss in the last 3 months. Same significant smoking history, but this time has an N2C neck with bilateral palpable lymphadenopathy. The patient is comfortable and no distress in your office, but with a hoarse voice, but no obvious stridor. And you have a CT and an endoscopy. So this is the tumor. Just move this out of the way. You can see here there is a right paraglottic mass and preepiglottic space mass. This is the preepiglottic space that is pushing on the endolaryngeal inlet, somewhat bulky. But once you get down to the level of the true cords and subglottis, that the airway opens up. So this is a tumor that there's right true vocal cord fixation, but intact left true vocal cord function.
Where are the nodes? Do you have a picture of the nodes?
Yeah, sorry, I don't have the nodes. I put that in from a discussion that this is a more advanced case. Sorry, I don't have a picture of the nodes. You can see here that this is the sagittal. Right, so this is the best image of it. The radiologist called this as slight minimal extension through the thyrohyoid membrane into some of the strap muscles, but it's hazy at best. So I put an arrow here. But this is a tumor that's largely within the larynx, but called with slight extralaryngeal extension. So this is actually not the patient. I sort of had to pick a representative image. So think about this as a advanced transglottic tumor with minimal subglottic extension, mostly in the glottis and supraglottis, endophytic, and as I pointed out in the imaging, minimal minimal extralaryngeal extension in the thyroid membrane. So this is a T4A N2C transglottic supraglottic with right vocal fixation squamous cell carcinoma with a 30-pound weight loss in 3 months, minimal extralaryngeal extension. So what are your plans for treatment? We'll go West Coast first. Arnaud, why don't you lead us out?
So, I mean, I think on a very broad sense, for T4, generally I'm thinking primary surgical therapy as being, the best option in terms of chance of cure. So certainly that would be my primary, my primary recommendation to the patient would be total laryngectomy, bilateral neck dissection. That said, it sounds like her laryngeal function is reasonable. You said airway's good and swallowing is relatively preserved, you said?
30-pound weight loss, but not terrible, but certainly not great.
Okay, yeah, it's right there on the slide. And it seems like it's just meeting the criteria for T4. I mean, there's no gross thyroid cartilage destruction. The cricoid seems fine. It's just this hazy invasion into the strap muscle. So I think consideration of definitive chemoradiation certainly should be entertained as well. I would send the patient to the radiation oncologist to have that discussion as well. I'd want both options considered.
So, Doc, you tell me what to do. I'm going to do whatever you tell me, Doc. You say, sir, I'm going to recommend you.
And then you take it out.
Okay, laryngectomy. Mike?
Yeah, I mean, I'd say the same thing, but I do think this is one of those that, it could at least be considered for non-surgical management, but I would lean towards upfront surgery, especially because of how bulky it is and the already, compromise in swallowing function.
Chase?
I think the odds of her coming out of non-surgical treatment with the functional larynx are pretty low. So I'd favor surgical management first.
Okay. Susan and then Don?
I agree. I would offer surgical management up front. I would discuss non-surgical management, but if they ask me for a recommendation, I would recommend surgery.
Don?
I would recommend surgery, but I would ask you about the nodal disease. If it's really low in the neck, I'd say this person's likelihood of chest involvement sooner rather than later is high, and chemoradiation really should be considered in that context. Oh. And going back to Babak's earlier point, if this patient has a complication with your operation, they're going to have a cancer failure. So your operation needs to be done very thoughtfully with regard to recon and everything else to minimize risk of fistula and delay of post-op chemoradiation.
Good points.
Babak?
Yeah, so this is a little bit tricky for a few reasons. Number one, you have a bulky tumor, but it's like what we call a soft T4, not a, like Chase's case that it was T4 from across the room. I think there is nothing wrong with upfront surgery, but with the understanding that she probably needs radiation and probably chemo RT if the nodes are bad. That's why I was asking about the nodes.
Sure.
That's one point. The second point is this patient, unfortunately, with this situation, I would say based on the NCDB data, 60% of the time we will get a chemo RT, and we all know that that's not going to help that much, and they're going to come back and either end up with a non-functioning larynx or persistent cancer. This would be a very good choice for induction. See what happens. If it shrinks, then continue with chemo RT. If it doesn't, you have your answer. You haven't radiated the neck, and just do a standard chemo surgery up front and followed by radiation or chemo. That would be one consideration for me, but there's nothing wrong with, she's 55. So she has, because of her smoking, her life expectancy is not into 70s probably, but she's not 10 years. And if you look at the data from the 3311, after 10 years, chemo RT versus RT versus induction was no change. So I'm not convinced that CCRT is the end all be all. I would do either surgery or induction. That would be my two choices.
So if this patient had no weight loss whatsoever and your speech language pathologist saw the patient, said their swallow is intact and functional, does that change your management, or would you still recommend a total laryngectomy based on the T4A status?
Oh, yeah. Actually, Dr. Trepea is on the phone. Doug, would you like to make a comment? If you're on mute.
Yeah, no, I'm on the line. I've been listening to the whole thing. It's really good. I like how all the Michigan data is being highlighted.
I know. Who's the usual suspect there?
Yeah. So I've been listening since the start. You guys are doing a great job. I don't need to pipe in all the time. Just to drop back, the paratracheal node dissection, you get a lot of tracheal necrosis. And so a lot of those patients were mine in the Michigan study. And I have to be honest with you, I kind of leave it alone, and in about 2 weeks, you can just trim out the trachea. There's a lot of other tricks that are done with free flaps and blah, blah, blah. There's a lot of little technical things, but often you'll get some tracheal necrosis if you've done those bilateral paratracheal node dissections, and you just literally can trim out the trachea. Usually it's 2 rings. If you wait for it, it's usually not a big problem. Yeah, this patient's asking for induction, right? And so basically, if you give a single cycle, and so it's almost what I would call bioselection. And can everybody hear me?
Yes.
Yeah.
Yeah.
If you do bioselection, so you give a single dose of chemotherapy, we would be old school, but it seems to be the best selector. So cisplatin 5-FU. 5-FU over 5 days in outpatient. Cisplatin obviously is a dose of massive hydration. And then you see what the response is. If the patient responds more than 50%, then they go on to get chemoradiation. So concomitant chemoradiation, no further induction. And 80% of the patients respond. And then 20% do not. And those patients then go on to get surgery. And so, yeah, I mean, and if you really look at our publication on 9520, which is in the literature under Susan Urba, URBA, as the first author, the survival rates are up around 76%. And then Greg Wolf comes back and he does a follow-up study, and then Carol did a whole bunch of biomarker studies, and so, which didn't really show anything, unfortunately. Yeah, I think this is beautiful for induction.
Great. All right. So time is almost up. Jeff, why don't you finish?
Yep. I'll close it out. I mean, funny, I was thinking people would favor organ preservation, but everyone wanted a laryngectomy, which I'm totally okay with. I think everyone would agree if the patient had a trach and G-tube before being able to start treatment, that would be more favorable for a laryngectomy. Just as contradistinction, here's a different tumor that's highly bulky. This is one that I think hands down, there's not a lot of argument for a total laryngectomy. So this is my last slide. I just want to thank everyone from CDMS for organizing. I get to be the last speaker of the last day. First, definitely hats off to JJ, who's kept this whole thing running with emails and the Zoom calls. Thanks to Chase, my co-moderator. Thanks to Babak and Mike for all keeping this organized and all our discussants and guests. So thank you very much. That's it.
Okay.
Thanks, guys.
Well, thank you all. We have actually another session next week, an extra session with the collaboration with the endocrine section. So please join us. That would be fantastic. It's been a fantastic month and a half that I definitely learned a lot. Thank you all collaborators, my partners in crime, Mike and Arno in the CDMS, Don at ATC, JJ at AHNS, and Susan, our own secretary. And thank you all the guests that made appearances, Dr. Chaklia today. Really appreciate Dr. Drew Ridge, who was here last week, and all the other experts who called in. The fellows have been very quiet. We would love for you guys to ask us questions, to make comments, and participate. This is for you guys. As you can see, obviously, we don't have all the answers here. And there's still a lot to be done.
We have all the answers. We just don't agree.
Well, we do agree with each other. It's just, just do it my way. All right. Okay, have a great night. I'll see you guys next week. And Dr. Greg Randolph and his team going to be joining us for endocrine cases. Stay safe.
Thank you.
Thanks, everybody.
Night, everybody.
Have a good night. Bye-bye.